Good morning, dear judges. My topic is intraocular pressure in premature infants. What is normal? I have no financial interest in the machine used. Understanding normative IOP value in preterm infants is crucial as deviation may affect visual development or indicate congenital ocular disorders. There is paucity of standardized data on IOP in premature infants, as well as its correlation with post-conceptual age, birth weight, and presence of ROP, especially in the Indian population. With the portable rebound tonometer such as the eye care, non-invasive IOP measurement in this population has become feasible even in the intensive care NICU setting. The aim was to determine the normal intraocular pressure range in premature infants using the eye care 200 rebound tonometer. The primary objective is to establish normal IOP ranges in premature infants, and the secondary objective was to correlate it with increasing post-conceptual age, birth weight, and presence of ROP. It was a multicentric longitudinal study, 60 eyes of 30 premature baby infants with gestational age less than 34 weeks were evaluated as part of a routine ROP screening program in the neonatal NICU unit across different hospitals in the Ernakulam district of Kerala. The post-conceptual age is gestational age plus number of weeks since birth. The infant was laid on his or her back in the incubator, and IOP was measured with an iCare IC200 rebound tonometer without the use of speculum. Right eye was examined first in all cases, and measurements were obtained between 9 a.m. and 12 noon. 3 IOP measurements were taken for each eye, and average IOP calculated and was repeated after 2 weeks. So these were my inclusion and exclusion criteria. In the results, in the baseline characteristics of the study participants, the the post-conceptual age ranged between 29 to 34 plus 2, with a mean of 31 plus 2. Gestational age 26 to 31 with a mean of 27 plus 6. Birth weight 1000 to 1890 with a birth weight average of 1421. And the categorical variables, the post-conceptual age was divided into 29 to 30 weeks, 31 to 32 weeks, and 33 to 34 weeks into 3 categories. And these were the numbers in those categories. The ROP, any grade, we did not divide depending on the grade of the ROP. It was just presence of ROP or not at this particular stage of the baby. And it was into yes and no. The difference in IOP between baseline and after 2 weeks, if you take all the eyes together, the mean IOP was at baseline 15.13, and after 2 weeks it reduced to 14.64 with a difference of 0.49, and this p-value was found to be significant. So there was a significant difference between baseline IOP and IOP after 2 weeks. The comparison of IOP with post-conceptual age in both eyes and its difference after 2 weeks, what you find is that the baseline IOP is higher in the lower age group compared to the higher age group. And a decreasing trend in IOP was noted in 3 groups after 2 weeks, but only group 1 was statistically significant. Comparison of IOP with presence of ROP was that significant difference in IOP in baseline values were noted in the babies who had ROP irrespective of the stage of ROP, and this was also found to be statistically significant. Comparison of intraocular pressure with birth weight, infants with lower birth weight showed a significant decrease in IOP values from baseline after 2 weeks, which means baseline, the measurement in the lower birth weight babies had a significant difference after 2 weeks when we measured the intraocular pressure. This is the correlation graphs showing a significant negative correlation between baseline IOP and post-conceptual age, and a significant negative correlation between after 2 weeks. This is baseline IOP and birth weight, and this is 2 weeks and birth weight. So various studies have been conducted to assess IOP in premature infants. Most of them were cross-sectional analysis, and very few longitudinal analysis has been done. The most recent longitudinal study by Monteira et al. In Portugal demonstrates that with a mean gestational age of 29.4 and a mean birth weight of 1222, mean IOP showed reduction every 2 weeks till the post-conceptual age crosses 37 weeks. Our study had a larger sample size of 60 eyes of 30 preterm babies, and we found that the IOP reduced after 2 weeks from 15.13 to 14.64, indicating a similar declining trend as in the previous study. We obtained a significant negative correlation with post-conceptual age as well as with birth weight. These are the related longitudinal studies that I have looked into, but most of them used a different instrument. The instrument used by the Montera et al. Study is what is we have also used, but that was a Caucasian population, and this is in our Indian population. But in all the studies, we can see that there is a declining trend, especially in the lower gestational age and the lower birth weight babies. The physiopathological mechanisms that explains this consistent IOP decrease is the increasing size of the ocular structures, anterior chamber angle maturation, progressive improvement of the aqueous drainage system, and neuroendocrine changes. Some advantages of our study is that we have not used an eyelid speculum, and none of them were sedated or given muscle relaxants during the examination that may interfere with the result of the IOP measurement. So in conclusion, mean baseline IOP values in preterm infants in a South Indian population was 15.13, that reduced to 14.64 after 2 weeks. Baseline IOP is higher in lower gestational age and lower birth weight infants, and a decreasing trend in IOP is noted after 2 weeks. Significant decrease was found with the presence of ROP, which correlates with the lower birth weight and lower gestational age. We do not give it any other for more significance. And to our best knowledge, this is a pilot study in Indian population to record the normative data of IOP in preterm babies. These are my references. Thank you.
This was a retrospective study or prospective study?
Prospective study.
Prospective. With in ethical considerations and all, they were all considered.
Yes.
What would be the reason for our population having a low IOP compared to the other population which has been mentioned in the literature?
We really don't have, for the baseline decrease, we don't have a explanation, but it could be that our population included lower birth weight babies also. So it was not exactly comparable, the babies that they have.
And
because this was based, a lot of the data is from infertility centers, so there was very preterm babies as well.
So we use the right eye for all the evaluations?
No. Both eyes, but right eye was examined first.
Okay.
Because just to, because there's crying for the baby when there'll be some disturbance. That's
so wouldn't it be better if we had no ROP and then just evaluate the right eye? For babies which, because here you'll have duplication.
Okay.
You'll have 60 plus, you'll have the IOP as magnified, and the lower IOP will show more lower than what was in the literature. Because although the advantage here is that we have not used the speculum, the other studies have used the speculum, almost all of them.
Except the Montera. Actually, the iCare 200 is the only device in which you don't need a speculum.
Exactly. Yeah, so the iCare, the tonopen and all would have definitely required the speculum. Yes. But if you add the eyes and then present the IOP, it shows a magnified view. So if you're looking at IOP reduction, usually the drug trials which we...
No, here we have not added the eyes. We have looked at right eye and left eye separately.
Separately, okay.
Yes. Left eye is also included. It's just that methodology, we have mentioned that right eye was examined first.
So when you add right eye and left eye, so the sample size sort of increases.
Yes.
So it will give you a... But it's patient-centric. It's not eye-centric. So patient-centric, if we talk, then it will be showing that our patients have lower IOP. There's the artifact which is put into the bias which has been put into the study.
You have examined the patient only one time, or how many? What was the duration between the 2 weeks?
So
why didn't you put the grading of the ROP? Did any children require laser or treatment?
They were removed from the calculation.
Totally excluded. Only no ROP patients. You have looked at whether the normal physiological. That's all.
Treatment.
So it's grade 1 and grade 2, or no ROP?
Yeah, it is divided into no ROP and patients who had any
so ROP 1 and 2.
Stage 1 and 2, yes.
Stage 1 and 2. That's what I'm asking.
Not
so stage 1 and 2 and no ROP were included. You have excluded from 3, 4 and 5,
3, 4 and 5 ഒന്നും ഇല്ല madam. 3 ആവുമ്പം treat ചെയ്യും. So patients who needed 3 were excluded.
Okay. So
And
that
we have measured the IOP 3 times. So to avoid to get the inter-observer each time 3 times.
The better way of letting them, not making them cry or something like that. How to?
These babies require only swaddling, because once they are swaddled and they are comfortable, the instrument itself doesn't cause much trauma. And because there is no speculum, no paracane application, generally they are comfortable.
Thank you. Thank you.
Thank you.